The next we call upon Dr. Manjit PS, who's an associate professor in Kottayam Medical College. He did his MBBS from Alappuzha Medical College and PG from Government Medical College, Madurai. He has done his vitreoretinal fellowship from Aravind, Madurai. Over to you, sir.
Good morning, all. So I'll be dealing with posterior segment manifestations of closed globe injury. So as said in previous talks, a sudden axial compression of the globe by a blunt injury begins with indentation of the cornea, a decrease in the AP diameter of the globe, a compensatory equatorial expansion, flattening of the posterior pole, and a posterior displacement of the posterior pole. So this axial compression and equatorial expansion will cause stretch on the peripheral retina at the points of normal adhesion. It also causes stretch at the areas of abnormal adhesion, and there is a differential expansion at the equator due to these stretch forces. These result in equatorial tears, vitreous base avulsion, pars plana tears, giant retinal tears, retinal dialysis, and horseshoe tears. The posterior pole flattening and displacement causes stretch in the posterior pole and anteroposterior contraction, which results in commotio retinae, choroidal rupture, RP rip, macular hole, and traumatic foveoschisis. Commotio retinae is the most common finding seen in blunt trauma as grayish-white glistening opacification of the outer neurosensory retina. OCT is a good tool to determine how much damage is there. In grade 1 injury, you just see some hyperreflectivity of the ellipsoid zone. In grade 2 injury, there is loss of interdigitation zone, disruption of the interdigitation zone. In grade 3, there is both disruption of the interdigitation zone as well as the ellipsoid zone. And in grade 4, along with this, you get disruption of the ELM, external limiting membrane. In such cases, usually you will see later foveal atrophy in these patients. Choroidal rupture is seen as a crescentic line concentric to the optic disc. If it affects the papillomacular bundle, usually it results in poor vision. In the periphery, choroidal rupture is seen as a line which is circumferential to the ora serrata. But during presentation, mostly you don't see the choroidal rupture because it will be obscured by subretinal hemorrhage. You may see some patients will have multiple foci of subretinal hemorrhage. On clearing this hemorrhage only, you will be able to see the choroidal rupture. RP rip. Here the ripped RP rolls up and forms a hyperpigmented area, and this is the area where there is no RP, which is more translucent, and in fundus fluorescent angiography, this is seen as a larger window defect. The blunt force creates a trampoline-like movement of the posterior pole, and the tractional forces that act tangentially along the surface of the retina can result in immediate formation of a macular hole. So the traumatic macular hole has some differences with the idiopathic macular hole. Idiopathic macular hole is a slow, insidious process, but traumatic can cause immediately, and patient has sudden decrease of vision. Usually the PVD is absent, and operculum also may be absent. But there are some good things about a traumatic macular hole. There are higher chances of spontaneous closure, especially in young males and in children. But also the prognosis can be guarded if there is associated injuries that like more RPE damage or associated choroidal rupture or associated optic nerve injury. A vitreous hemorrhage can result from a retinal or a choroidal tear or from PVD, and it can also occur without an obvious retinal tear by just shearing of the capillaries. If you see a patient with no fundus view due to vitreous hemorrhage and a grade 3 or 4 RAPD, you have to always rule out optic nerve avulsion. In the ultrasound, there may be hemorrhage in the area over the optic disc, and you can see the vitreous all dragged towards the site of the optic nerve head, the presumed site of optic nerve head, and there may be a small cavitation at the site of the optic nerve head. So the different trauma, different breaks that occur in the blunt injury can be due to a direct injury at the direct point of contact, a coupe injury, or on the opposite side, the counter-coupe mechanism. Equatorial tears are said to be pathognomonic of trauma. They can be multiple, large, and can have fragged edges. Traumatic giant retinal tears, unlike the idiopathic retinal tears, they may have irregular and ragged edges and may have multiple fragments. And usually they are seen in younger patients and predominantly in the supratemporal quadrant. Retinal dialysis, they usually occur in children and young adults, commonly in the infratemporal quadrant and also on the directly opposite side of trauma, that's in the supranasal quadrant. Vitreous base avulsion appears as a bucket handle tear. So vitreous base avulsion, equatorial tears, they are all said to be pathognomonic of previous history of trauma. Not all trauma results in breaks immediately. Sometimes new breaks can appear after the onset of a PVD, and a PVD in trauma occurs generally by around 1.5 to 2 months. So 10% of detachments are found immediately, 30% in 1 month, 50% within around 8 months, and 80% within 2 years. B-scan ultrasound may be helpful to identify RD in a vitreous hemorrhage or an optic nerve emulsion. OCT will helpful to know the severity of the macular hole to identify RP rib and the grade of commotio retinae, and rarely you may need an FFA or ICG to assess choroidal rupture or vascular compromise. Sometimes trauma can even cause a central retinal artery occlusion. So management, proper fundus evaluation is needed once the media becomes clear. You have to monitor the patients for delayed retinal breaks or detachment. Even when the patient has a normal fundus at presentation, later the patient can have retinal breaks. Treat a retinal detachment with laser, buccal or vitrectomy. For a macular hole, you can wait for around 1 to 2 months if the hole is decreasing size, because macular holes can have some lineage closure. Address vitreous hemorrhage surgically if non-clearing. So all wish to assess the severity of the posterior segment trauma to determine the visual prognosis. It is the posterior segment trauma that determines the final visual acuity generally. And regular follow-up is needed to assess late complications, and proper counseling is needed before taking up for surgery, because the complications can occur even more than 1 year later. Thank you.
Thank you, Manjit sir, for this